Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. We are tackling a beast of a topic today, one that I think terrifies nursing students and, frankly, seasoned providers alike because of the sheer volume of information. We're talking about pediatric health supervision.
It really is a massive topic. I mean, you open up the health supervision chapter in any standard pediatric nursing textbook, and it feels like you're staring at a wall of guidelines, growth charts, vaccine schedules. It's overwhelming.
Exactly. It's the kind of chapter where you try to highlight the important parts and you just end up highlighting the entire page.
The whole thing ends up yellow.
So we're going to do something a little different today. We're going to apply the Pareto principle.
The 80-20 rule. I love this approach for this specific subject.
Right. The idea that, 80% of your exam questions and honestly, 80% of the critical safety catches that keep kids healthy, they come from just 20% of the material. So our mission today is to aggressively filter the source material. We want to separate the nice to know context from the need to know survival guide.
That's the goal.
Yeah.
We're not here to memorize every footnote. We're here to identify the red flags. The things that, if you miss them, a patient gets hurt, a diagnosis is delayed.
Or you fail the board exam. And to keep us grounded, so we aren't just reciting lists in a vacuum, we're going to anchor this entire discussion around two specific patients from the case studies.
Good idea.
Let's introduce them. First, we have Maya. She's 3 years old. She's in the clinic today for a sore throat. But here's the kicker. She hasn't been seen by a provider since she was 1.
Oof. Which is a huge red flag immediately. That's a 2-year gap in a critical developmental window.
Exactly. And then we have her little brother, Evan. He is 9 months old, and he has literally never been seen by a doctor.
Wow.
No birth shots, no newborn screen, nothing.
So this is a perfect storm for a pediatric nurse.
Yeah.
You have an acute issue, Maya's throat. But underneath that, you have this massive deficit in health supervision.
Right.
You have to. I mean, you have to pivot instantly from fix the problem to assess the whole child.
So let's unpack this using our 80-20 framework. We'll start with the principles of supervision. The text spends a lot of time defining the medical home. Now, reading through this, the nice to know part is that a medical home isn't actually a building.
Right. That's a common misconception. It's not the clinic down the street. It's a relationship. It's a philosophy where care is accessible, family-centered. But if we drill down to the need to know,
the part that actually impacts things.
Exactly. The part that impacts clinical logistics, it's about data centralization.
Because the medical home holds the centralized database of the child's history. And in our case with Evan, since he's never been seen, he doesn't have one.
Which means we are flying blind. We don't know his growth trajectory. We don't know his risk factors. Without that centralized history, every decision is a guess.
So establishing that home is priority 1 for him.
Absolutely.
The other sort of context piece the text highlights is cultural orientation. It mentions that the U.S. healthcare system is inherently future-oriented. We do things today, like vaccines, to prevent things 5 years from now. But that can clash with some cultural perspectives, doesn't it?
It does. Some cultures are present-oriented or even fatalistic. They might believe health is determined by harmony with nature or a higher power. So if Evan's parents seem non-compliant,
you can't just assume they don't care.
You can't. The need to know takeaway is that it might not be negligence. It might be a fundamental mismatch in time orientation. You have to bridge that gap, not just judge it.
Okay, let's get into the hard data. The numbers you absolutely have to memorize. Developmental screening. The guidelines are incredibly rigid about the timing here.
This is high-yield territory. If you are taking notes, circle this. You need to memorize 3 specific ages for universal developmental screening. 9 months, 18 months, and 30 months.
So 9, 18, and 30. It doesn't matter if the kid looks like a genius, you screen at those intervals.
Correct. It is universal, no exceptions.
And looking at our patient Evan, he is exactly 9 months old.
He falls right into that first bucket. We cannot let him leave without that screening.
Now, in addition to that general screening, there's a separate track for autism spectrum disorder, ASD. And that has its own cadence in the notes.
It does. ASD screening is specifically mandated at 18 months and 24 months.
So that 18-month visit is a heavy hitter. You're doing the general screen and the autism screen.
Exactly. That 18-month visit is just critical for catching neurodevelopmental delays.
Okay.
But while those numbers are important, there is one concept in this section that overrides everything else.
Okay.
It's the biggest red flag in pediatric development.
You're talking about the loss of a milestone.
Yes, the need-to-know rule is absolute here. If you have a child who loses a developmental milestone, say a baby who could sit up and now at 9 months is flopping over, or a toddler who is speaking and now is silent.
That is a medical emergency.
A full stop medical emergency.
That's not a let's watch and wait until the next visit situation.
Never. Watch and wait in that scenario is malpractice. Loss of a milestone indicates a significant neurological problem. It could be a brain mass, metabolic, severe regression. It demands an immediate, full evaluation.
That's a really powerful takeaway. The other observation point the text makes is that we shouldn't just be looking at the child. We need to look at the dyad.
The parent-child interaction. And this is often more valuable than any checklist.
Yeah.
Does the parent make eye contact?
Yeah.
How do they handle it when Maya throws a tantrum?
Right.
If Evan is crying and the mother seems completely detached or unable to soothe him, that is a clinical data point. It suggests a risk for neglect or bonding issues.
All right, let's move to segment 2. I call this the sensory and safety blog. We're talking eyes, ears, and environmental hazards. The source material goes into the physics of hearing tests, the AABR versus the OAE.
Which is fascinating, but firmly in the nice-to-know category, unless you're training to be an audiologist.
Right.
As a nurse, you just need to know the test was done. The need to know is the timeline.
The 136 plan.
Right. Screen by 1 month. Identify the hearing loss by 3 months. Start treating by 6 months.
And why is that 6-month deadline so strict?
Language development. If a child can't hear by 6 months, the language centers of the brain actually begin to prune away those pathways. If you wait until they are a year old to treat it, you've lost a window of brain development you can never get back.
Wow. Now, digging into the risk factors, there's a specific exam trap regarding the NICU.
Yes, and they love to test on this. The cutoff is 5 days. If a baby was in the NICU for more than 5 days, they are automatically high risk.
And often those babies are on specific antibiotics, right?
Exactly. Ototoxic medications like gentamicin. So you see a case study of a 6-month-old who seems fine but had a complicated birth with a 10-day NICU stay. Your first thought should be, has his hearing been rechecked?
Let's shift to vision. We have Maya, who is 3. The challenge here isn't just does she see, but how do we get her to tell us?
Yeah, you can't use the standard Snellen chart with the alphabet. She can't read yet.
So what's the tool?
For a preschooler like Maya, the need-to-know tool is the tumbling E chart, where they just point which way the E is facing, or the Allen figures, which are pictures of a bird, a cake.
Okay. And for Evan, he's 9 months. He's not pointing at birds.
For infants, we are just looking for fixation and tracking. By 2 months of age, a baby should be able to follow an object 180 degrees across their field of vision. If Evan isn't tracking you as you move, that's a referral.
Got it. Okay, let's talk labs. Specifically, the newborn metabolic screening, the heel stick.
Which Evan missed.
But for a newborn, the text is very aggressive about the timing.
The timing is critical. It must be done after 24 hours of age, ideally between 24 and 48 hours.
I think the natural instinct is the sooner the better. Why do we have to wait a full 24 hours?
It comes down to biology. We are screening for metabolic disorders like PKU, which is an inability to process protein. To detect that, the baby needs to have ingested and digested enough protein.
From breast milk or formula.
Right, to trigger the metabolic markers.
So if you do it at 4 hours of life, the system hasn't been challenged yet.
Exactly. You get a false negative. The baby has the disease, but the test says they're fine. So if a baby is screened before 24 hours, the rule is it must be repeated.
That is definitely a safety critical point. Let's talk about lead. The reference level is 3.5 micrograms per deciliter. But as a nurse, you're often playing detective with the housing history.
You are. The magic number here is 1978. That is the year lead paint was banned in residential housing.
So if Maya and Evan's parents say, We just renovated this beautiful Victorian home built in 1960.
Alarm bells should be ringing. The dust from that renovation is the primary way kids get poisoned.
And the screening schedule aligns with that exploration phase, doesn't it? We screen at 12 months and 24 months.
Right, because that is when they are crawling on the floor and putting every single thing in their mouths.
Speaking of things in mouths, let's talk about anemia. The 12-month mark seems to be the hotspot for that, too. And there's this concept of the milk trap.
This is a huge need to know for nutritional counseling. We know we don't give cows milk before 12 months because it can cause microscopic GI bleeding.
Right.
But even after 12 months, there is a risk. The milk baby phenomenon.
What's that?
You'll see a toddler who looks chubby and healthy, but is actually severely anemic. What happens is they are drinking 30 or 40 ounces of milk a day. They are full, so they don't eat iron-rich solid foods.
And the milk itself interferes.
Yes, the calcium in the milk actually blocks iron absorption.
So for Maya, at 3, if the parents say, oh, she's a picky eater, but she loves her milk, she drinks 5 bottles a day, we need to check a hemoglobin immediately.
Absolutely. She is a prime candidate for iron deficiency anemia.
All right, take a deep breath. We are moving into the zone that I think stresses people out the most. Immunizations.
It is the most complex section. But again, let's apply the Pareto principle. We aren't here to memorize the protein structure of the measles virus.
No, we need to focus on safety and administration. So let's start with administration. Where are we poking these kids? I feel like I see variation in practice, but the text is very specific about the rules.
The rules are based on anatomy and safety. For infants and toddlers, basically anyone who isn't walking well yet, you use the vastus lateralis, the thigh muscle.
And we absolutely avoid the arm for babies.
Yes. Do not stick a needle in a baby's arm. The deltoid muscle is not developed enough. You risk hitting the radial nerve or hitting bone. And you also avoid the gluteus, the butt, because of the sciatic nerve.
So for Evan, at 9 months, every shot goes in the thigh.
Every single one.
And for Maya, she's 3. She's running around.
Since she is 3 and has adequate muscle mass, we can move to the deltoid. The general rule is thigh until they are walking securely, usually transitioning around 12 to 18 months, but definitely by age 3, it's the deltoid.
What about needle size? I assume using an adult needle on Evan is a bad idea.
It is. For infants in the thigh, you want a 1-inch needle, maybe 58-inch for a newborn. If you use a needle that's too short, you aren't getting into the muscle. You're just injecting into the subcutaneous fat.
Which means the vaccine won't work as well, or it causes a nasty local reaction.
Exactly. Intramuscular means in the muscle.
Okay, let's talk contraindications. When do we stop? When do we look at the chart and say, no, absolutely not, we cannot give this shot today?
The biggest category here is live vaccines. The main ones are MMR, measles, mumps, rubella, and varicella. Chickenpox.
Because they contain a weakened version of the actual virus.
Right. So the absolute need to know is you do not give live vaccines to anyone who is immunocompromised. If a child has leukemia or is on high-dose steroids, you can't give it. And you cannot give it to anyone who is pregnant.
Okay. And what about the timeline for those live vaccines? Because Evan is 9 months old. Can he have his MMR today?
No. The weight rule applies here. We generally do not give live vaccines until the first birthday, 12 months.
Why is that?
Yeah.
What's the science there?
Maternal antibodies. The baby still has some protection from mom floating around in their blood. If we give the live vaccine too early, those maternal antibodies just attack the vaccine virus and kill it.
So the baby's own immune system doesn't get a chance to learn from it.
Exactly. It renders the shot useless. So we wait until 12 months to ensure those maternal antibodies have faded enough for the vaccine to take.
Got it. So Evan gets no MMR today. Now, looking at specific vaccine risks, the text mentions rotavirus and something called intussusception.
Intussusception is a medical emergency where the bowel telescopes into itself. It folds in like a collapsible cup. If a baby has a history of that, they cannot have the rotavirus vaccine because it increases the risk of it happening again.
And for the DTaP-P, the diphtheria, tetanus, pertussis shot, there's a neurological warning.
Yes, encephalopathy. If a child had a coma, decreased level of consciousness, or prolonged seizures within 7 days of a previous pertussis shot, that is a hard stop.
You don't give it again.
You do not give the pertussis component again.
While we're on the alphabet soup, DTaP versus Tdap. Big letters, little letters. I know students mix this up constantly.
It's actually a simple code for dosage. Capital letters mean a full-strength dose. Big D, DTaP-P, is for little kids under 7. Their immune systems are immature and need that big antigen push to wake up.
And the little letters.
Little d, Tdap, has a reduced dose of diphtheria and pertussis. That's the booster for older kids and adults, usually starting at age 11 or 12. Their systems are mature. They just need a gentle reminder.
So big letters for little kids, little letters for big kids. That's easy to remember.
It works every time.
One last critical point on vaccines documentation. It isn't enough to just scribble giving in the chart.
Not even close. You are creating a legal medical record. You need the manufacturer, the lot number, the expiration date, the exact site. Left vastus lateralis, for example, and this is the one people forget, the edition date of the VIS.
The VIS being the vaccine information statement.
Right, that specific handout you gave the parent. If there is a recall 5 years from now, we need to know exactly which batch Evan received.
Okay, let's move to our final segment, health promotion. This is the lifestyle stuff. Nutrition, safety, hygiene. It feels less clinical, but the text argues this is where most injuries happen.
Oh, absolutely. This is where we protect the child from the environment. And honestly, sometimes from the parents' well-intentioned mistakes.
Like sun safety. I feel like I see parents slathering sunscreen on newborns at the beach because they think they're being responsible.
And that is actually incorrect guidance. The need-to-know rule is no sunscreen for infants under 6 months.
Not at all.
None. Their skin is thinner, it's more absorbent, and their ability to metabolize those chemicals isn't mature yet. Under 6 months, the strategy is avoidance.
Shade, hats, long sleeves.
Exactly. After 6 months, you can use SPF 30+D.
That's a clear cutoff. What about oral health?
We call it the dental home. Just like the medical home, they need a dentist. This should happen by 12 months of age or 6 months after the first tooth erupts.
And the warning here is about the bottle, right?
The bottle rot trap. This is a classic exam question and a real-life tragedy. Never put a baby to bed with a bottle of milk or juice. The liquid pools in their mouth all night, and the sugar just destroys the enamel.
Lastly, let's talk about screenings for things we usually associate with adults. Hypertension and cholesterol. It seems wild to check a toddler's blood pressure.
It does, but with the rise in childhood obesity and congenital heart issues, it's mandatory. The text says universal screening for hypertension begins at age 3.
So Maya, our 3-year-old patient, needs a blood pressure cuff today.
She does. And make sure it's a pediatric cuff, or the reading will be wrong.
And cholesterol.
Hyperlipidemia screening happens once between 9 and 11 years, and again between 17 and 21.
That seems incredibly young.
It is, but the research shows that atherosclerosis, the hardening of the arteries, can actually begin in childhood. If we catch high lipids at age 10, we can intervene with diet before they need statins at age 40.
Okay, we have covered a massive amount of ground. Let's bring this all together. I want to do a rapid-fire recap of the golden rules we just established.
Let's do it.
Developmental screening timeline.
9, 18, and 30 months.
Autism screening specifically.
18 and 24 months.
The biggest red flag for development?
The loss of any previously acquired milestone.
Newborn metabolic screen timing.
After 24 hours of age to ensure protein intake.
Hearing screen strategy.
The 1-3-6 rule. Screen by 1 month, identify by 3, treat by 6.
Lead poisoning risk factors.
Housing built before 1978, reference level is 3.5.
Vaccine site for an infant like Evan.
Vastus lateralis, the thigh. No arms till they are walking.
Live vaccines like MMR.
Not before 12 months. Not for immunocompromised or pregnant patients.
And sunscreen.
Not before 6 months.
That is a solid cheat sheet right there. So let's look back at our case study one last time. We have Maya and Evan sitting in the clinic. Based on everything we just discussed, what is the game plan?
Okay, for Evan at 9 months, he is due for that critical 9-month developmental screen. We check his growth. He needs his immunizations caught up, likely DTaP, polio, Hep B, but absolutely no live vaccines yet.
And all those shots go in the thigh.
All in the thigh. And since he has no medical home, we need to assess his lead risk based on his housing age.
And Maya?
Maya is 3. She gets her first blood pressure check. She needs a vision screen using pictures, the Allen figures or the tumbling E. We assess her language. She should be speaking in short sentences, and we check her immunization history.
And if she needs shots?
Since she's walking, those can now go in the deltoid.
It really puts it into perspective. When you break it down like that, it's not just a checklist of chores, it's a safety net.
It is. And that leads me to one final thought for everyone listening.
What's that?
We talked a lot about screening and shots, things that we do to the patient today. But the text emphasizes anticipatory guidance.
Predicting the future.
Exactly. The true art of health supervision isn't just handling Maya's sore throat. It's looking at Evan's mom and saying, hey, in 2 months, he's going to start pulling up on furniture. You need to anchor your bookshelves to the wall now.
Before he can do it.
Before he can do it. That's the difference between a technician and a true provider. You aren't just treating the child in front of you. You're treating the child they will be in 6 months. That is what saves lives.
That's a powerful place to leave it. Focus on that 20% that keeps the kids safe, anticipate the next step, and the rest will follow. Thanks for diving in with us.
See you next time.